Hello, everyone. Today, I will be talking about Friederic ataxia. Although Friederic ataxia is a rare disorder, however, it's one of the most common hereditary ataxia. Before talking about Friederic ataxia specifically, let's go over the ataxia. It's in the brain of everyone. It's in the mind, I mean, of everyone, that ataxia is a physical finding that more often linked to the cerebellum. In fact, this is not true. There are many other factors that can be contributing in the ataxia. If you have an abnormal sensory input into the cerebellum, such as a disease that involves the proprioceptive system or the dorsal column, can also result in ataxia. And if you are having any severe polyneuropathy or any muscle weakness, it can also be playing a role in the ataxia. The first thing that you have to do when you are approaching a patient with cerebral ataxia is to do a full neurologic examination. Before starting the neurologic examination, there are some question keys that can help you to make the diagnosis. What I would recommend you that to ask the patient, are you having any difficulty going up the stairs or down the stairs? Do you need to hold on the railing to be able to use the stairs? Or ask him, do you have any difficulty in running? Any trouble in walking in high heel or barefoot on the beach? Do you have any problem in switching from, in veering from one side to the other? Do you feel sometimes that you are working like a drunk? All those questions can help you confirm or deny or can lead you in a way or another if the patient is having ataxia or not. Unfortunately, late in the disease, as the ataxia progress, those patients can present to you with a frequent fall. And I have seen 2 to 3 patients, honestly, who presented to me with a frequent fall. One of them happened at the airport before boarding. It turned out that she is having multiple sclerosis. And in fact, this patient has been having ataxia for a while, but she didn't pay any attention for it, or she didn't seek any medical attention, saying it's going to go away, it's going to go away. However, on the other side, early in this stage, in patients with having ataxia, they can have some visual disturbances, such as blurry vision or slurred speech or loss of hand dexterity. This is the list of acute causes of cerebral ataxia. I'm not going to go over them. Just very quickly, you can divide them into acute, subacute, and chronic. The most important thing is when it's acute is to order MRI of brain to rule out ischemic stroke or bleeding. Acute can be also to alcohol intoxication or to exposure to toxin. Keep in mind multiple sclerosis all the time. It should be always in the back of your mind. The subacute cause of cerebral ataxia can be due to paraneoplastic cerebral degeneration, a brain tumor, or other etiology. The chronic cases, most of them are genetic, and the most common one is Friedreich ataxia. You can have also episodic causes of cerebral ataxia, such as genetic episodic ataxia, psychogenic ataxia, mitochondrial disease, and multiple sclerosis. In fact, when you do a neurologic examination for ataxia, it has to be a full neurologic examination. I mean, not only ask him to walk, you have to check on the eye, speech, hand, legs, and gait. And it's why I'm saying so. In fact, because several abnormality of the eye movement can be seen in different type of ataxia. Like you are having saccadic intrusion in fixed gaze that can be seen in Friedreich ataxia. You can have horizontal or vertical end gaze nystagmus that can occur in many ataxia, among which downbeat nystagmus that very often seen in spinocerebellar ataxia type 6. So the findings on the eye exam can sometimes help you to know what type of ataxia you will be encountering. The 3 most commonly used task for ataxic hand examination is finger to nose test, the finger chase, and the fast alternating movement. You have to check for the patient mobility and equilibrium. You have to ask him to stand and to walk in front of you. What are the laboratory tests that you should be doing? Always, you have to have an obsession to do vitamin E level. Again, it has to be an obsession to do vitamin E level. I have seen at least 7 or 8 patients over the last few years who are having ataxia secondary to vitamin E deficiency, and usually they respond well to medicine, or at least to stop the progression of the disease. So vitamin E level and vitamin B12 level. You can also order for serum antibody level, such as anti-GAD antibody. You can ask for serum antigliadin antibody that can be used, that can be found in patients with gluten sensitivity. In patients who are having ataxia, You can also order anti-thyroperoxidase antibody. All these antibody are usually done in one panel. If you go to if you send them to a lab in a big center, it's choose them and you can have them done. You have always to check for paraneoplastic antibody. I also recommend to every one of you to go ahead with lumbar puncture. Although there are some people who mentioned that there is no need to do LP in ataxia, I believe definitely it has to be done. How do you approach patient who's presenting to you with ataxia? I'm sorry if the slide is a little bit complicated. I'm going to try to simplify it as much as I can. If you have a patient with suspected ataxia, first of all, you have to do a history and physical examination. Check if there is no sign of Parkinsonism, there is no vestibular problem, there is no sensory mononeuropathy or neuropathy. Then check if it's confirming ataxia. First thing that you have to do, MRI of brain with no hesitation. An imaging of the brain is a must in patient with ataxia. Once you have done the MRI of brain, sometimes you can make the diagnosis from the MRI findings. There are some specific changes that can be seen on the MRI that can help you to make the diagnosis in disease like superficial siderosis, chronic disease, Wernicke encephalopathy, or Fragile X syndrome. What you can do at the same time, and that's what I recommend, is to do the blood workup that I have told you. Some people wait until the MRI is out. No, I believe that MRI and the blood test should be done at the same time. Afterward, you have to check for the family history. If it's an autosomal dominant family history or autosomal dominant disease, it means this is one of the type of cerebrospinal ataxia. There are many of them. If it's an autosomal recessive, keep in mind Friederic ataxia. It can be mitochondrial. When it happens more than 60 years old, take into consideration Parkinsonism. It's mainly multi-system atrophy. Multi-system atrophy is the combination of Parkinson's disease plus autonomic dysfunction. Those patients can present with ataxia. So keep it in the back of your mind when you have someone above 60 years old coming to see you for ataxia. Let's talk now about Friederic ataxia. Friederic ataxia is a rare progressive neurodegenerative disorder. This is one of the most common type of hereditary disorder that's accounting for almost 50%. As I have said, it's an autosomal recessive disorder that's secondary to GAA triple repeat. What is very important to know is, unfortunately, it's not only limited to the nervous system. In fact, Friederic ataxia will affect anything in your body, the musculoskeletal, cardiac, and endocrine system. Patient with Friederic ataxia will start having the symptoms between 5 and 15 years old, and usually by mid-20s, they are already lost, they lose their ambulation. In fact, like I have said, it starts between 5 and 15 years old. It's a progressive in onset. However, one of the main symptoms that you need to look into when you have a patient with Friederic ataxia is the cardiac involvement. Cardiac involvement with cardiomyopathy occur early in the disease. And in fact, what happened is that those patients have to be sent as soon as possible to the cardiologist to rule out cardiomyopathy. And cardiac disorder is one of the main deaths of patients with Friederic ataxia. This is why it's crucial to send them to the cardiologist for an echocardiogram. Usually 8 years after the onset, those patients will start having a problem in the gait, and they are wheelchair bounded by 15 years of the duration of the disease. Unfortunately, the half-life or the lifespan of patients with Friederic ataxia is short, and their average life expectancy is around 37 years old. One of the main problems that patients with Friederic ataxia will be facing is loss of ambulation. And what happened is at the beginning, they start by unsteady gait with general clumsiness and frequent fall. They have difficulty after that, they have difficulty in tandem gait. Then they have difficulty to walk on uneven terrain or in poor light. Afterward, they will get into a stage where they have to depend on furniture to be able to walk. And ultimately, they are wheelchair bounded, or they have to use crutches or a walker or anything to help them walk. In fact, like I have said, unfortunately, Friederic ataxia do not only affect the nervous system. And when it affects the nervous system, it will affect the central nervous system and the peripheral nervous system. This disease will affect every part of our body. In the central nervous system, it will be responsible for limb and gait ataxia, for weakness, for spasticity. It affects also the peripheral nervous system with absent TTR and sensory loss. Those patients will have difficulty in their speech with dysarthria. They can have a musculoskeletal abnormality. Very frequently, we can find patients with scoliosis. Cardiac will be affected, like I have said a few minutes ago, especially with cardiomyopathy, arrhythmia, and heart failure. The endocrine system is also affected with diabetes mellitus. Late in the disease, those patients' sight can be affected where they cannot be able to see anymore, as well as they will have a problem in hearing. The pathology or the symptoms behind all the clinical symptoms of Friedreich ataxia is due to the fact that there are three main areas that's being affected in our body: the large fiber sensory system, the cerebral coordination system, and the corticospinal system. When the large fiber sensory system is being affected, there's loss of sensation and DTR. When the cerebral coordination system is affected, there is ataxia with loss of arm coordination and dysarthria. When the corticospinal motor system is affected, there is weakness of lower extremity and occasional spasticity. As the Friedreich ataxia progresses, there are other locations that's being affected: the skeletal muscle, the small fibers, auditory nerve and cochlear nucleus, the bladder, and finally the retinal and with vision loss. The non-neurological complications are quite common. One more time, and I know that I'm repeating myself, but this is just to show you how it is important to check for the heart status. Cardiomyopathy is present in almost all patients with Friedreich ataxia. It can occur early in the disease. Diabetes mellitus is estimated to be between 10 and 65% of the cases and usually develop later in the disease. Scoliosis is present up to 94% of the patient, and unfortunately, it can progress with time. Foot deformity can be seen between 55 and 90%, I'm sorry, but all depends on the age and disease duration. Those are the different pathology that can be found across the evolution of Friedreich ataxia. You can see on my left side, the scoliosis with bone fracture and depression and anxiety usually occur early in the disease. When late in the disease, you are having hearing and visual loss, as well as arrhythmia and psychosis. And in fact, diabetes, bone fracture, and depression can occur at any time during the disease. Like I have said, the lifespan is unfortunately very short. Most deaths will occur between 16 and 45 years of age. People with earlier onset and cardiac involvement have more severe disease than the patient with premature death. 60% of individuals with Friedreich ataxia die from cardiac complication. One more time, congestive heart failure and arrhythmia are the common cause of cardiac-related disease. Other causes is aspiration pneumonia, diabetic coma, stroke, and trauma sequela. In fact, unfortunately, living with Friedreich ataxia had a huge impact on the quality of life of the patient. And the main challenge that face people with Friedreich ataxia are as following. First of all, limitation in mobility and walking. Emotional issue. Can you believe it? Those people will be told you have a disease that unfortunately there is no treatment for it, although there have been some breakthrough medication over the last few years showing that it can help. And then the fatigue associated with the disease, loss of manual dexterity, where those patients are unable to feed themselves, the pain, social limitation in activity, feeling a lack of control. This is very bad. I mean, can you imagine that the patient is sitting and he's unable to stand up and go to the toilets if he needs to go? And finally, dysphagia. What is the pathophysiology and disease mechanism? Don't worry, I'm gonna get you all the detail of the pathophysiology. Myself had a huge problem understanding how it works when I was preparing for the lecture. To simplify it, it's very simple. In fact, there is a mutation on the chromosome 9 for what we call FXN. This FXN will be responsible for the production of frataxin protein, or FXN or frataxin protein. Frataxin protein is a very important protein for the work of the mitochondria. When the mitochondria is being affected, there is production of toxic material that have a bad effect on the system. And you know there is mitochondria everywhere. And this is why in patients with Friederic ataxia, they have a different, they are affected by the disease all over the body. It is estimated that 96% of people with Friedreich ataxia are homozygous for GA expansion, and 4% are compound with they are in heterozygous form. In fact, the longer the GA trinucleotide repeat, the more is early onset of the disease, and the more is the rapid progression. This is what I have just told you before. So the frataxin protein is being affected. When the frataxin protein is being affected, there is accumulation of iron in the mitochondria. When there is an accumulation of iron in the mitochondria, there is abnormality in the Krebs cycle, and there is a product and the oxidative reduction reaction. This will lead to the production of toxic material. The toxic material will have a bad effect on our body. I hope it was simple. How do we diagnose Friedreich ataxia? This is very interesting slide, in fact. This shows the path that unfortunately the patient with Friedreich ataxia will be going through during the disease. Early in the disease, when the patient presenting with ataxia, he will be seen by a primary care physician, and then he will be referred to the specialist. Very often, there is very wrong diagnosis because they are seeing for back pain. This is scoliosis. They are coming with ataxia. This is something else. And in fact, they are being referred to another specialist, and then referred to another specialist, and then finally someone, or they are being seen by a movement disorder specialist. Well, he will realize that there's a problem, and they will go for genetic testing. And when the genetic test is being done, those patients will start doubting the diagnosis. No, this is not true. I want to repeat the genetic test. Maybe the lab is wrong. So they have to repeat it again. And we do, most of the time, I do repeat it to relieve the patient. Finally, we make the diagnosis, and then we have to go into genetic counseling and explain to the patient and to the family about the disease. Like I have told you, it takes time, and it is estimated, this is a study that was published a few years back, showing that, in fact, the mean time to diagnosis in patient with Friedreich ataxia who had a neurologic onset were 4.1 years versus 6.5 years for patient with non-neurological onset. So you see how long sometimes it takes, unfortunately, to make the correct diagnosis. But this is not surprising, in fact, because not too many people know about Friedreich ataxia, and it's a relatively rare disease. How do we approach a patient who's presenting in general with ataxia? Like I have told you, always keep in mind that you have to do genetic testing. To check for vitamin E level. Always check for vitamin E level. And if you are suspecting Friedreich ataxia, go ahead and order genetic testing. If this is typical of Friedreich ataxia and the genetic test come back, it's normal, so this is probably Friedreich ataxia. If the patient is having, if the genetic is positive, but the patient is having some abnormal feature like spasticity, late onset, this can happen, but it means that they still have Friedreich ataxia. And then when you confirm the diagnosis, you have to check if you have 2 expanded or 1 expanded. If it's 2 expanded, you have to go ahead for the full workup, including electrocardiogram, echocardiogram. You have to do a film X-ray of spine. You have to check for blood glucose. If you have 1 expanded, you check for the frataxin mutation to check if it's really FA or not. If it's FA, it means this is the case. If it's not Friedreich ataxia, you have to look for something else. When you have any doubt, don't forget to do an MRI of brain and vitamin E level, like I have said. You have sometimes a lot of disease that can overlap with Friedreich ataxia, such as Charcot-Marie-Tooth or Refsum disease, or sometimes vitamin D deficiency. This is the symptoms of Charcot-Marie-Tooth. They have sensory ataxia, absent DTR, and they can present as well as Friedreich ataxia. However, on nerve conduction study, you will be able to differentiate between 2 of them. Autosome ataxia associated with vitamin E deficiency, AVID. Those patients will present with gait and limb ataxia. They have dysarthria, areflexia, sensory loss, which is quite close to Friedreich ataxia. However, when you check for their vitamin E level, it's low, and they have some titubation that you don't see usually in patients with Friedreich ataxia. So to confirm the diagnosis of Friedreich ataxia, you have to do genetic testing. The genetic testing usually it's occur in two process. First of all, you target testing for GA expansion in the FXN gene using PCR or sudden blot technique. If only one expanded is needed, you can do the sequencing of FXN gene. And once it's being done, you can confirm or not if the patient is having Friedreich ataxia. Once the diagnosis is being made, you have to have a family meeting. In fact, you have to call mom, dad, the brother, sister, and explain about the disease. Try to tell them what are the progression, what can you offer to the patient. If they want to check if they are carrier, if the mom and dad are asymptomatic, check if they want to check if they are carrier of the disease, or if they want to check with someone else. I usually, if the other member of the family is asymptomatic, I mean brother or sister, I don't recommend to do genetic testing, because let's assume that they have the disease. Is it going to make any difference? Of course not. I mean, and if we decide to treat the patient, we'll treat them when they become symptomatic. And when we will not treat anybody or give them any medication if they are asymptomatic. Finally, I have two assessment scores. I'm going to go over them very quickly just to let you know about them. They are being more used in research than in the clinical practice. The first one is a Friedreich ataxia rating scale. You can see it on the right side. The drawback of this, it's complex and it takes time. And then recently they have been doing the modified Friedreich ataxia rating scale, where they check for bulbar symptoms, upper limb, lower limb, peripheral nerve, and upright stability and gait. This one is easier and it takes less time. The second one, this is the result. The second one is SARA, which is scale for assessment and rating of ataxia, where you assess them for between 0 to 40, with a higher score correlating with poorer neurological function. I think I will end here. If you are interested, in fact, you can scan this QR code, and you can. There is a form that can be filled out, and someone will reach out to you. Will be happy to send you all the information about Friedreich ataxia. Thank you. Yeah, in fact, this is a very good question, and I didn't want to talk about it because it's not UAE approved yet. However, in fact, I knew that someone's going to ask me this question in a way or another, because this is a really breakthrough in the management of patients with Friedreich ataxia. Yeah, there is a medicine that has been approved in the US, and there is around 1,200 patients on the medicine now. It's called omaveloxolone, or Skyclarys. In fact, this is a medicine that showed that it reduced the oxidative toxic material. It will reduce the oxidative stress in Friedreich ataxia. It also will restore the antioxidant capacity through the increased production of glutathione, which is typically decreased in Friedreich ataxia. Omaveloxolone will rescue mitochondrial function in Friedreich ataxia, and this has been showed in multiple studies. It will have also it will play a role in suppressing the pro-inflammatory mediator involved in neuroinflammation, and it will prevent the programmed cell death in the fibroblast. Just to show you this study, which is very interesting, I didn't want to go over the pathophysiology. That's why I went over it very quickly. But this is very interesting study. It's called MOXIE. It's part 1, part 2, and extension. In fact, they recruited around 100 patients with Friedreich ataxia. 51 of them received once a day 150 milligram of omaveloxolone, versus 52 they received the placebo. The primary endpoint was the modified Friedreich ataxia rating scale, and then there was some secondary endpoint, and then there was also safety and tolerability. But let me show you this, how interesting it is. There was a significant improvement between the patient taking omaveloxolone versus the patient taking placebo. You see that there is a significant difference by Nathan, and it's statistically significant. And it's very interesting. It means that this medicine not only help in the progression of the disease, but it can be even reverse it. I do understand that this is the beginning, but it's a good start to find a medicine that can at least have, even if it's a minimal improvement, can help. This is also to show you the benefit of this medication after 48 weeks, showing that there is a significant difference between the patient taking omaveloxolone, I really having a problem to pronounce it, versus the patient taking placebo. Also about the side effect, in fact, the side effects were minimal, but you have to check for liver function test. It is recommended to do LFTs before and after. It is recommended to stop the medicine if it's more than 3 times the normal value. But as I have told you, it's relatively rare, but you still have to do it. This is also showing that chances of liver injury are relatively low, but it doesn't mean that you don't have to give the medicine. Those are the side effects: palpitation, atrial fibrillation, cardiac arrhythmia. However, they were relatively low. It was 7 in the placebo group versus 5 in the cardiology. That's it. Thank you.